Now, let us discuss the steps to diagnose tachyarrhythmia from ECG pattern in detail. Step 1. Analyze the heart rate. Tachyarrhythmias are associated with a heart rate greater than 100 bpm. Therefore, you should first check the heart rate by using the 10-second rule or by 300 rule. In a 10-second rule, you need to count the number of QRS complexes present in a 10-second period and then multiply the number by 6. Step 2. Analyze the rhythm. Tachyarrhythmias usually have an abnormal rhythm. Therefore, you should check the RR interval in the given ECG strip to determine whether the patient has a regular or irregular rhythm. Step 3. Check the width of the QRS complex. The width of the normal QRS complex is 60 to 120 milliseconds. Tachyarrhythmia is characterized by a narrow or wide QRS complex. A narrow QRS complex has a duration of 120 milliseconds, 3 small boxes. It indicates that the ventricles are depolarized through the His-Purkinje system. On the other hand, a wide QRS complex has an interval of greater than 120 milliseconds. It indicates that the ventricles are not depolarized normally. Step 4. Check the morphology of P wave. While examining the P waves, you should check the aspects such as: are P waves present? Do P waves precede each QRS complex? Do all the P waves have a uniform shape or have a varying shape? Does P wave have normal configuration? The absence of P waves before a QRS complex indicates that the rhythm is either atrial fibrillation or the impulse originates in the AV node. P waves that are present but not clearly associated with QRS complex are indicative of heart block. Step 5. Determine the PR interval and PR ratio. The duration of the normal PR interval is 120 to 200 milliseconds, or 3 to 5 small squares. You can measure the PR interval by counting the number of small squares between the onset of the P wave and the beginning of the QRS complex. Then multiply the number of squares by 0.04 seconds. A long PR interval can be observed in patients with atrial tachycardia and a typical AV nodal reentry tachycardia. The normal PR ratio is 1:1. If the PR ratio is 2:1, 3:1 or greater, it indicates that the patient has focal or macro reentrant atrial tachycardia with AV nodal block. Step 6. Check if the onset of palpitations is gradual or abrupt. A gradual onset suggests sinus tachycardia, whereas an abrupt onset suggests an arrhythmia. Ectopic beats are the extra heartbeats that arise from the impulses generated at points in the myocardium other than the sinoatrial node. The
physiological
pacemaker. Ectopic beats are the most common cause of irregular pulse. They are also referred to as premature contractions or extrasystoles. They occur early in the cardiac cycle, before the next sinus beat, and are followed by a gap in the pulse known as a compensatory pause. The compensatory pause prevents the propagation of the next sinus beat. Depending on the actual location, they are classified into 2 types: supraventricular ectopic beats, and the other is ventricular ectopic beats. Let us now discuss in detail about the supraventricular ectopic beats, or SVEB. A supraventricular ectopic beat is an early atrial depolarization which originates either in one of the atria or outside the sinoatrial node. It is characterized by a premature QRS complex in the ECG. SVEBs occur singly or in groups and indicate atrial irritability. An isolated SVEB is not significant, but a high frequency suggests a higher risk in the patients. An increasing trend in SVEBs may be an indicator or sign of atrial fibrillation, which may lead to a heart attack or stroke. ECG criteria of supraventricular ectopic beats include: the QRS complex is premature relative to the baseline RR cycle. A narrow QRS complex can be seen if the patient has a bundle branch block. P wave may be inverted, notched, biphasic, or retrograde, narrow, or normal QRS. In the ECG strip shown here, you can find a premature QRS complex in the lead 2. They are narrow and resemble QRS complexes of the sinus rhythm. Therefore, they can be identified as supraventricular ectopic beats. Let us understand a little about ventricular ectopic beats. Ventricular ectopics are the early heartbeats that begin in the ventricles and are characterized by a wide and bizarre QRS complex. Ventricular ectopics may be isolated or may be few in a row, bigeminal or trigeminal pattern, or in couplets or triplets. If more than 6 ventricular ectopics are present in a row, it indicates ventricular tachycardia. The primary symptom reported by the patients with single ventricular ectopic beats is skipping a beat. Ventricular ectopics may be positive or negative complexes. If the QRS complex in lead V1 is positive, it indicates that the impulse is coming from the left, and it is traveling toward the right. If the QRS complex in lead V1 is negative, it indicates that the impulse is coming from the right, and it is traveling towards left. If some ventricular ectopics on the rhythm strip are positive and some are negative, they are collectively referred to as multifocal ectopics. If the ventricular ectopic falls so early that it interrupts the T wave of the preceding complex, then it causes a high risk of ventricular tachycardia or fibrillation. The table here depicts different types of ventricular ectopics, namely unifocal, multifocal, interpolated, and couplet. Let us discuss each one in detail. Unifocal, it has a similar configuration in all leads and originates from a single ectopic ventricular focus. The QRS complex is similar. Multifocal, it has a variable configuration of ectopics in the same lead because the ectopic originates from a different focus of the ventricle. The QRS complex is variable. Interpolated, ventricular ectopics occur between 2 normal sinus beats without the compensatory pause. Couplet, 2 ventricular ectopics are in a row. The table here explains about the ventricular bigeminy, ventricular trigeminy, and grouped ventricular ectopics. Ventricular bigeminy. Each normal beat is followed by the ventricular ectopic. Ventricular trigeminy. Every 2 normal beats are followed by the ventricular ectopic. Grouped ventricular ectopics. 2 to 5 consecutives ventricular ectopics. The table here explains about the ECG criteria of ventricular ectopic. QRS complex is bizarre and wide, greater than 120 milliseconds, or more than 3 small squares. Preceding P wave is absent, and T wave is opposite to the major deflection. The R wave of ventricular ectopic occurs on or near the peak of the previous T wave. It is called malignant ectopic as it indicates ventricular fibrillation or ventricular tachycardia. In the given ECG strip, lead 2 has premature ventricular contractions, which are caused by an early ectopic impulse within the ventricles. They occur after a sinus P wave before a normal QRS complex, below the bundle of His, which extends depolarization resulting in a wider QRS complex that is often bizarre in shape or between 2 consecutive sinus beats. The ECG strip has a wide QRS complex, greater than 5 small squares, as the impulses are generated from the ventricles, and action potentials travel slowly from one myocyte to another. You can also find a compensatory pause between 2 QRS complexes showing a PVC and a duration twice the distance of other RR intervals.